Thank you, Pam. Wonderful, wonderful talk. And now on to triglycerides. And then we'll complete the circle and have a real quick discussion around the table. And it's my honor to present you with Dr. Robert Rosenson, who's a colleague here at Mount Sinai, professor of medicine, director of the Metabolism and Lipids department here at Mount Sinai Health System for the entire health system. He is an very, very prolific researcher, clinician, scientist. He's led so many clinical trials from phase 2 all the way to phase 4, and he's received multiple awards and, of course, also on editorial boards and on section editor for JACC for all of the metabolic disorders, as well as the section editor on lipid disorders for Up to Date, and co-editor and chief for cardiovascular drug and therapeutics. Wonderful, and my honor to have you here, Rob, to talk to us about the role of triglycerides.
Well, thank you, Roxanne. It's really a great pleasure to be here and participate in this conference. And I'm just going to, there we go. These are my disclosures. And trying to get this, there we go. When we think about elevated triglycerides, our major concern is the risk of acute pancreatitis. But this occurs at extreme level of triglyceride levels. And from this analysis of more than 7 million individuals who are hospitalized for cardiovascular disease and other causes, we looked at the lipid panel proximate to the episode of acute pancreatitis. In individuals who have not had an episode of acute pancreatitis in the preceding 12 months, there is a greater relationship between triglycerides and an episode of pancreatitis, but it's quite low. In contrast, if your patient had one episode of pancreatitis in the preceding year, the risk of having a recurrent episode at triglyceride levels over 1,000 increases 24-fold. If they've had 2 or more episodes, it increases about 47-fold. The point is that if you have elevated triglycerides, it doesn't mean that you have to rush off to pharmacotherapy. You have an opportunity to work on the foundation, which is lifestyle changes, reducing saturated fat to decrease chylomicron production in the intestine, decreasing refined carbohydrates to decrease VLDL production by the liver. You also have the opportunity to counsel on exercise and muscle strengthening. What we want to focus on is the other part of triglyceride risk, which is clinical atherosclerotic cardiovascular disease. All of the triglyceride particles contain apolipoprotein B. The particles that are made in the intestine, the chylomicrons and the remnant particles, contain a truncated form of ApoB known as ApoB48. The ones that are synthesized by the liver, the VLDL, and some of the catabolic lipoproteins such as IDL and LDL have apolipoprotein B100. They all contain apolipoprotein B, and that's a very important concept as we discuss the failure of some of the clinical trials. In this genetic analysis conducted by Ference, individuals with ApoB normal or the common variants do have a high risk of cardiovascular disease, and loss of function variants is shown over here, a much lower risk of cardiovascular disease. Looking at this at a tabular form, we can see that per 10 milligram per deciliter lower ApoB, the risk of coronary heart disease is 23% less. And that relationship is stronger than it is for LDL cholesterol or triglycerides. So again, keep in mind apolipoprotein B when you think about triglycerides. Now, the very low density lipoprotein, major atherogenic lipoprotein, hepatically synthesized, contains a lot of proteins that affect triglyceride metabolism that may affect the ability to hydrolyze those triglycerides in the circulation. And let's discuss some of these proteins in the next slide. So genetically, we know that many of them, where we have loss of function mutations, you have lower triglycerides because you have increased lipoprotein lipase activity, the ability to break down those VLDL particles, and a lower risk of cardiovascular disease. That's the importance of genetics. In this large study from the Copenhagen General Study, 75,000 individuals, it turns out that 42% of the variation in hypertriglyceridemia is influenced by clinical variants, but 21% by clinical variables, and 21% by common variants in 7 loci, and 1% have rare genetic variants. The point is that many individuals who have hypertriglyceridemia have a genetic basis for that hypertriglyceridemia. And this doesn't even account for the polygenic hypertriglyceridemia, which may be even more common cause of hypertriglyceridemia in most individuals. With regards to coronary disease, those who have loss of function mutations in ApoC3 lower levels have lower rates of coronary heart disease, as shown in this study from the NIH Triglyceride and HDL Working Group. What about therapy? What do we do? This is a post-hoc subgroup meta-analysis of the fibrate trials, the PPAR-alpha agonists, which do increase lipoprotein lipase activity and lower triglycerides. What Frank Sachs and Jean-Charles Fouchard did is they looked at individuals with triglyceride levels that are elevated, greater than or equal to 200 milligram per deciliter and a low HDL, and compared that to the other groups that were included in these trials. And those individuals with what they called dyslipidemia had a significant reduction in cardiovascular events compared to the groups without the dyslipidemia, the lower triglycerides, higher HDL cholesterol. And this post-hoc subgroup analysis served as a major stimulus for triglyceride lowering with PPAR-alpha agonists, the fibrates. But this was a post-hoc analysis. Paul Ritger evaluated this prospectively using a more selective PPAR-alpha agonist called pemafibrate. This was the prominent trial. And the prominent trial failed to reduce cardiovascular events despite reductions in triglycerides of 26%, remnant cholesterol 26%, apolipoprotein C3 of 28%. Perhaps it was due to the increase in LDL cholesterol expected when you lower triglycerides and you decrease VLDL and convert to LDL, but it may be the increase in ApoB. Why was there an increase in ApoB? Pemafibrate interferes with statin absorption, and so without a change in ApoB, no benefit. So what do we do today? What do we do for individuals with moderate to severe hypertriglyceridemia? Well, if the triglycerides are under 880 milligram per deciliter or 10 millimole per liter, we use moderate to high dose intensity statins. The first paper in the literature with atorvastatin, the Baker-Arkema paper published in JAMA, showed that high doses of atorvastatin in individuals with triglycerides of 200 to 880 lowered it by 44%. Similar results were seen with rosuvastatin in a similar population, lowering triglycerides by 40%. And statins reduce apolipoprotein B and reduce cardiovascular events. It may not be sufficient. There are other studies that are underway. The SHASTA-2 trial is an MRA inhibitor directed against ApoC3. 3 parallel arm studies, placebo-controlled, that we presented at the American Heart Association meeting in November. There were reductions in ApoC3 as much as 87% and reductions in triglycerides of 86%. And the full results will hopefully be presented at AHA this November, and we're designing a phase 3 clinical trial to determine whether ApoC3 inhibition reduces cardiovascular events. Not only the reduction in triglycerides, reductions in non-HDL cholesterol, increases in HDL cholesterol. Dr. Sabatine's group is leading a trial with an ApoC3 inhibitor, an antisense oligonucleotide, olezarsen, and here's one of the studies, 540 participants with high triglycerides. And there will be an open label extension, so that may be the first trial looking at this pathway. And these are some of the inclusion criteria, but in the interest of time, I'll just point out fasting triglycerides greater than or equal to 500 milligram per deciliter. There's another target, angiopoietin-like 3, which is approved as a monoclonal antibody for lowering LDL cholesterol in patients with homozygous FH. This is an siRNA inhibitor, and we evaluated this in individuals with mixed dyslipidemia. Again, 3 parallel arm groups, as you can see here. And in the interest of time, reductions in angiopoietin-like 3, reductions in triglycerides of 56 to 59%, reductions in LDL cholesterol of up to 32%, non-HDL cholesterol 34 to 45%, and reductions in remnant cholesterol. Importantly, in contrast to the TIMI Translate 70 trial, which showed an increase in hepatic fat fraction, we reported a dose-dependent reduction in hepatic fat, and non-alcoholic fatty liver disease is a common accompaniment of hypertriglyceridemia. So when we think about pharmacotherapy, the likelihood of lowering triglycerides without changing ApoB to reduce cardiovascular events, is poor. That ApoB is superior as a predictor of risk than remnant cholesterol. However, if you can lower triglycerides and reduce ApoB, there's an opportunity for reduced cardiovascular events, but a hypothesis that remains to be tested. So we've got 2 new classes of medications. There's a lot of overlap, and how this is all going to pan out in terms of study design is something that I'm involved in, and I'm sure other panelists are involved in as well. But ApoC3, very effective for triglycerides, less effective for LDL, angiopoietin-like 3, almost as effective for triglycerides, and much more effective for LDL cholesterol. So the future is bright for triglyceride lowering. The proof is in the trials, and stay tuned. Thank you very much.